Welcome back to Let's Go Shorts Episode 2. I'm Pete Ammon, an obesity medicine specialist from Portland, Maine. Last episode, we spoke about the disease of obesity and the many comorbid disease processes which can be caused by and occur with obesity to affect someone's health. Having obesity and these comorbid diseases can significantly affect quality of life. Furthermore, having a BMI in the Class 3 obesity range, which is above a BMI of 40, is associated with decreased life expectancy, estimated to be about 6.5 years of life lost. This risk increases the heavier a person is. Any amount of weight loss can lead to major health benefits and likely improved longevity. However, sometimes the patient who carries the extra weight is less likely to get the medical care he or she needs and less likely to have the needed screening tests for diseases that they might be at increased risks to suffer with. This fact is likely related to bias and stigma a patient may endure when they do go for medical help. Imagine you go to the doctor's office for a visit for knee pain, and the chairs in the waiting room are too small for you to comfortably sit in, so you stand. When you are brought back to the exam area, you are weighed in the hall, but the scale cannot accommodate someone of your size. You are brought into an exam room and given an examination gown to wear, but it is too small, and it feels like your backside is open to the wind. The blood pressure cuff they use does not fit comfortably around your arm. When the doctor finally comes into the room to talk about your knee, all she notes is that your weight is high, which is probably why your knee hurts. She spends less time in the exam room with you than she might with a person of lower weight, and does not prescribe you physical therapy or home exercise program, since she figures she will not follow up with the treatment plan. Would you ever go back to that office? We have known for decades that weight stigma and discrimination exist. Obesity bias occurs at work, in healthcare settings, at home, and in schools. Physicians and other medical providers have a large amount of weight bias. Physicians tend to spend less time in office visits with patients with obesity, provide less education to patients with obesity, and patients who report history of healthcare bias have poor healthcare outcomes. They likely avoid care. There are too numerous to count studies looking at the horrendous bias patients with obesity suffer in the healthcare settings. Physicians generally don't want to discuss weight as much as they have to, don't feel prepared to discuss nutrition, and feel that treatment of obesity in their practice is ineffective. In healthcare, we under-refer to programs that are successful, like bariatric surgery programs. Weight stigma refers to social devaluation and denigration of individuals because of their excess body weight, and can lead to negative attitudes, stereotypes, prejudice, and discrimination. Feelings of being stigmatized can put a person at risk for lower self-esteem, depression, and lower quality of life. Weight-based stereotypes include generalizations that individuals with overweight are lazy, lacking willpower, incompetent, unmotivated to improve their health, and non-compliant with medical treatment. And weight discrimination refers to overt forms of weight-based prejudice and unfair treatment toward individuals with overweight or obesity. Not surprisingly, patients tend to internalize this stigma and bias. Weight bias internalization occurs when individuals engage in self-blame and self-directed weight stigma because of their weight. Internalization includes agreement with stereotypes and application of these stereotypes to oneself and self-devaluation. There's both explicit weight bias and implicit weight bias that we can have towards ourselves. Weight bias is damaging, especially to individuals who develop weight bias internalization. This can lead to binge eating, depression, increased anxiety, suicidality, poor quality of life, and lower rates of health screenings. Over the years or decades, a patient's physical and mental health can spiral out of control. Promoting awareness around obesity physiology is going to be a key factor in improving the bias that our patients with obesity face. People who believe that weight is under individual control and that it will be changed when people just eat right and exercise more have much more obesity bias than do individuals who have better understanding of the physiology of obesity. When we speak to individuals that carry extra weight, getting comfortable with the terminology they feel most at ease with can help promote improved relationship with healthcare teams and help improve their ongoing involvement in healthcare settings. Patients often feel better about talking about their weight or their BMI, but using the term morbid obesity, fat, or large are less comfortable for patients and can be triggering. In addition, we need to recognize that when our patients have weight bias internalization, helping them understand that working on those internal biases will promote their health. Asking a patient permission to talk about their weight and potential health concerns can be helpful for patients to exert some control in their own health care. Focusing on health benefits, even with a small amount of weight loss, and setting realistic goals with patients can be helpful. Frequent check-ins on progress can be beneficial and can involve your entire team. At MaineHealth, we have developed an adult obesity primary care program called Small Steps to highlight the incremental progress patients can have to slowly improve their health, 1 pound, 1 meal, and 1 day at a time.